Welcome, everybody. Greetings. Welcome to our exciting mental health lecture series. This is day 3 of the series, and if you have just joined us, we welcome you. If you have been journeying with us, we ask you to just stay with us until Sunday when we conclude this series. We are in partnership with Pan American Health Organization, as well as the Ministry of Health and Wellness, Western Regional Health Authority, and the Department of Psychology, Sociology, and Social Work at the University of the West Indies, Western Jamaica campus. This evening, 2 exciting speakers are with us, and to moderate the evening's event, we have Ms. Joy Chambers, who is the coordinator of adolescent service in the Family Health Unit at the Ministry of Health and Wellness. Over to you, Ms. Chambers.
Thank you very much, Dr. Crosby. And welcome everybody, and thanks for that introduction. And this is going to be a very exciting afternoon because there's so much information to be had. And we have 2 exciting speakers, as was mentioned before, Dr. Kevin Goulbourne, Director of Mental Health and Substance Abuse in the Ministry of Health and Wellness, and Dr. Peter Gay Reynolds, Consultant Psychiatrist, Northeast Regional Health Authority. We're changing up the program a tad this afternoon because Dr. Goulbourne has another engagement at 6, so it, of course, is going before Dr. Reynolds. However, let's hear something about Dr. Goulbourne. He hails from the cool hills of Malvern in St. Elizabeth, where he obtained his formative education at Bethlehem All-Age School. After completing his secondary education at Monroe College, he pursued his first medical degree, an MBBS, at UWI-Mona, and later specialized in the field of psychiatry in 1999. He has special interest in drug abuse treatment and completed his 2007 Hubert Humphrey Fellowship in Drug Abuse and Health Services Management at Virginia Commonwealth University in the USA. He currently serves as board member of Patricia House, a drug rehabilitation facility in Kingston. He is the chairman of the National Council on Drug Abuse, and he has attended conferences and training here and overseas in the field of psychiatry. He served as the regional psychiatrist in the Western Regional Health Authority from 2000 to 2010, and later worked for a few months as a consultant psychiatrist at Bellevue Hospital. For the past 7 years, he has occupied the post of medical director of the Medical Services Branch in the Jamaica Constabulary Force, where he has been involved in ongoing drive to encourage healthy lifestyles and early intervention in treating medical conditions through regular screening members of the JCF. Since April 2018, he has occupied the post of Director, Mental Health and Substance Abuse in the Ministry of Health and Wellness. He's married to 1 wife, the love of his life. And in his spare time, he likes to engage in outdoor activities such as football, cricket, cycling, and lawn tennis. And he's also a member of the Runaway Baptist Tabernacle. What a mouthful. But help me welcome Dr. Kevin Goulbourne. And today, he is going to be looking at reducing stigma associated with a career choice of mental health. Dr. Goldberg, over to you.
Thank you, Ms. Joy Chambers, for that kind words of introduction. And I would like to also thank the organizers for staging a timely conference and inviting me to speak on this topic, reducing stigma associated with a career choice in mental health. So for this afternoon, we'll look at 3 main learning objectives. Stigma, what is that? How is stigma developed? And ways of decreasing stigma. So when you review the literature, there are many types of stigma, but I choose these 4 types of stigma for this evening's presentation. There's social stigma, structural stigma, self-stigma or internalized stigma, and courtesy stigma. Now, stigma can be considered to be a negative attitude of one person or a group of persons towards another person because of a particular characteristic of the person who is stigmatized. So let's look at social stigma. This is when there's an obvious negative attitude towards another person displayed by another person. And it's manifested by discriminatory behavior, which may cause negative interpersonal interaction. So, for example, when I started work at College Hospital as a psychiatrist, I remember vividly one old boy saw me and asked me, "So what are you doing now, Kevin?" I said, "Well, I'm working here. Recently came here to work." He said, "What field are you in?" I said, "Psychiatry." You could see the disdain in his face and his disappointment. So from early on in my career as a psychiatrist, I felt social stigma. Then there's structural stigma. And this is seen in large companies and institutions like schools and hospitals, where through their policies, they put certain restrictions and rights and opportunities on individuals who are stigmatized. Then there's what we call courtesy stigma or stigma by association. Here you see a negative attitude which extends someone due to the link you may have with another person who has an undesirable characteristic. So in my experience, and experience of many psychiatrists, my colleagues, is that because we have psychiatric patients who are stigmatized themselves, so we get stigma by association, and goes further into structural stigma where hospitals, including private hospitals and especially private hospitals, where they previously admitted psychiatric patients there, they develop policy in recent times where they no longer allow admission of psychiatric patients to the institution.
Dr. Goldberg, a moment, please. Sorry to interrupt you. Can you share your screen with us, please? Sorry about that.
Thanks. It's okay now?
Yes, absolutely. Thanks.
So we look at social stigma, structural stigma, stigma by association, and then we also have self-stigma. And this is where we have mental health workers accepting the negative evaluation by others as being true. And this not only cause to accept this negative evaluation, but cause one to feel less valued as a person and decrease your self-worth and have a negative sense of who you are. So that is self-stigma. How is stigma formed? It is formed out of general public opinion. So depending on which society you are in, you may feel a certain stigma towards mental health workers. It's due to the training that person are exposed to as healthcare workers. But we do know that a lot of stigma does exist within the health system and the health workers. It's also due to the way medical care is provided within our facilities, whether it's primary facilities, secondary facilities, whether it's private facilities or public facilities. It also be formed due to where the media portray issues related to mental health and mental illness. So these are simple cartoon that's showing that one way that society sees and wants us to see ourselves as if we are this person over here who is a mental health worker and whose sanity has left him. So he has become like his patients. And that's one way person perceive. Even when I try to do psychiatry, that's one of the fears my family and friends have, that with time, I become like my patients and my sanity will leave me. So stigma is formed and demonstrated in the society, especially when the mental health worker is seen as the ones or the agents or proponents of ineffective and brutal treatment. And this is stemming from psychiatric historical treatment, where in the up to the late 1900s, before that time, most of psychiatric treatment was custodial care. The person had been tied up and removed from society. And we see what happened even in our country, Jamaica, here at Bellevue Hospital. The person was exposed to shock treatment. So the mental health worker was seen as participants and agents of barbaric treatment. And how they describe persons who treat mentally ill? They describe as shrinks. Or I used to have a account of a person who told me that I'm a shrink. I said, no, I'm not a shrink. I'm an expander. I help person to expand their horizon to achieve their goals. They see us as mad doctors who prescribe mad pills, and general mental workers, mad people worker. And then persons who treat persons living with mental illness are seen as persons who are either touched or with time become touched, as if mental illness is contagious. And we also think that what we are doing is ineffective, that our medication is ineffective, tend to be addictive, where persons once they start on it, as some of my patients say, doctor, I have to live on this medication. And some patients and relatives will say that all it causes them to do is to sleep and sleep. It doesn't seem to help in their underlying psychiatric problem. They also see that as mental health workers, our treatment don't help persons to function. The person who was irrational and aggressive because of their psychiatric illness, their psychosis, when given the medication, they're transformed into zombies. So we are seen as doctors who don't help patients to get better at all, and mental health workers who don't help persons to get better at all. Also, we are seen as not real doctors, because we tend to do more talking, and talk is cheap. Although persons are very ignorant of the training and expertise and knowledge that goes into what we call talk therapy. And my patient demonstrated where sometimes they'll come over the phone saying they don't have enough money to come to my private office, but yet in talking to me, they make reference to go and see the gynecologist who would have to pay to see. How is stigma formed among healthcare workers, especially among doctors and nurses? They tend to downplay the importance of mental health in the delivery of a comprehensive health care, where they do everything else, every other area, orthopedics, obstetrics and gynecology, but because of mental illness and mental health issues, they tend to have a hands-off approach. And then in assessment, in the training of healthcare workers, especially doctors and nurses, psychiatry is not seen as a part of the final decisive test. Yes, they may have done tests earlier in the training, but when it comes to the final exam, well, in medicine, we talk about obstetrics and gynecology, pediatrics, internal medicine, and surgery. And then among healthcare workers, as mentioned before, in my earlier experience with my fellow mono-old boy, we've seen that we are in a profession of low associated prestige and respect. And before, not with medicine, we are wasting time. And because there's no physical criteria for diagnosis, there's no temperature to take, there's no X-ray to take, even though that is changing with time, they don't think we are practicing real medicine at all. What about the media? Yes, the media at times display in movies, and though it may seem as a movie, it's a show, but it plays on our mind, and it's them display psychiatrists and other healthcare workers as ineffective and useless. They tend to be very sensational, so they portray medical team primarily involving using brute force to bring psychiatric patients into submission. And when it comes to reporting, they tend to always want to look for a sensational story that report negative outcome of patients. And having reported negative outcome of patients, by extension, it's also having a negative reflection on the medical team, that our patients are not doing well and they're causing mayhem in the society, and that's why they should be put away. What about in the practice of medical care? I know many experienced physicians who are clamoring for separate psychiatric units in general hospital, not realizing that patients do get better within their hospital setting, and that quite a number of the patients who are medical, surgical, obstetrical and gynecological issues, that they have psychiatric problems. And in that sense, they all have issues, and they probably all should go to a psychiatric unit then because they have psychiatric problems. Also, in the practice of medicine, we see where inadequate spaces are located for outpatient psychiatric services. In some instances, it's a small spaces given for psychiatric clinics. And there's a lot of tokenism. When there are programs developing and agendas developing, a lot of times mental health is added just for convenience sake, so criticize that you leave out mental health. And then not to mention the fact that in our policy change, we are treating psychiatric patients on the medical ward. And we thought to do a bit of integration between secondary care doctors and the psychiatric treatment, but it doesn't happen so easily. A lot of times, the doctors and the nurses do pass over. Where I come to the psychiatric patient bed, they pass over that patient and give patient scant regard, as if that patient is not a patient like any other patient who has not only psychiatric problem, but also physical problems. How do we go about reducing stigma? Well, as mental health workers, we have to make sure and don't allow the opinions of others determine our work and our worth. We need to have a good sense of who we are and the worth of our intervention and our profession in helping persons who we serve and their families. Also, a lot of times people don't like us or they have stigma against us because they don't know of what we are doing. And if people knew what we are doing, then the stigma may be less and our image could improve. Now, of course, policy and restrictions are enacted to exclude undesirable persons, to keep people out. And that's a structural stigma. So what ways could we use to decrease stigma? Well, in the general public, we seek to have mass media to improve the perception of the role of the mental professions, and also to improve the awareness of what mental health is, mental illness is, and how persons who have mental illness can actually improve and become productive members of society. So we need to improve the perception of the role that we play. Also, if persons have more contact with persons who have been treated for mental illness and have recovered, then persons will have a different view of the work we do. A lot of times, persons tend to just focus on those persons who are obviously mentally unwell, eating out of the garbage bin, were unkept, maybe uttering a lot of incoherent speech, and so what people see as mentally ill persons. And also testimonials from patients and families about mental care and its effectiveness can also help to decrease the general public opinion about the work we do and about our profession. Also, we need to go out there and offer ourselves to provide public education in different settings. So National Association like Jamaica Psychological Association, Jamaica Psychiatrist Association should collaborate with stakeholders like the police force, Ministry of Education, in trying to infuse in their programs, in their curriculum, mental health awareness. And currently we are doing so with what we call school mental health literacy program within schools. Also to take the opportunity to present to different organizations within communities like churches, service clubs, community clubs. We should also seize the opportunity and sometimes present ourselves to present to private and public bodies, companies, and agencies. Because some stigma reside in workplaces, and we need to educate them as to what mental health and mental illness is and what it is not. And we mustn't forget our own colleagues in other health associations like the Nurses Association of Jamaica, Medical Association of Jamaica, Association of Physiotherapists and Radiographers. Because as I mentioned before, there's a lot of stigma sometimes originating among our fellow healthcare workers, and we need to try to reduce that stigma amongst them against us as mental health workers, against our patients. We also need to look at the delivery of medical care. We need to include mental team in management of patients, and the big term for that is consultation, liaison, and psychiatry. We realize that the input of the psychiatric team is important in managing patients, because patients are not just physical being, or social being, but they are being with a mind, and if the mind are working properly, it affects the overall improvement in the person and the person's health. We also need to look towards further integration of mental care in the primary and secondary care level, where physicians and nurses and other healthcare workers feel more comfortable in looking after persons who have mental illness within their settings, will even make a diagnosis and initiate treatment early and refer where it is deemed necessary. And then another proposal is to also have continuing medical education in the context of psychiatric liaison service, where in these same year hours, persons will get exposure maybe to case histories of persons who have had psychiatric conditions in different medical settings and how they are handled. So persons can become more and more comfortable in dealing with psychiatric patients and referring patients to the psychiatric team for their input to have an improved outcome in the patients. And just remind persons that psychiatrist is a medical doctor first and a psychiatrist second. So that time then, as psychiatrists, when we do consultation liaison and psychiatry, we should ensure they understand, we do understand other things outside of psychiatry, and that we use those other knowledge in order to make our psychiatric intervention. What about healthcare worker training? So we need to make sure when training students in different health fields, to make sure they get a more accurate picture of psychiatry as a discipline and have positive role models. So yes, before I went to psychiatry, I realized psychiatrists in the a bit off and so on, but thanks to my role model of the late Dr. Petagaye, I saw in him someone who was very level-headed, have a good sense of humor, and yet he was a good psychiatrist. Then the exposure of skills and approaches used in psychiatry is very useful in general medicine practice. Because our practice of psychiatry, we do what we call therapeutic alliance, but not only that, we tend to understand how patients are interacting with us, and by our understanding that, we utilize that to ensure they don't feel that we understand what they're going through. We are able to help them to feel that we are on their side and we are supporting them, and that way, the what we call therapeutic alliance, which goes a far way in patients taking medication. And that is a skill which, if utilized across medicine, make a great difference, because a lot of, especially non-communicable diseases, tend to get worse, like hypertension and diabetes, because of poor adherence or poor taking or compliance with taking medication. And then nothing that will occur is teaching done by consumer and professional. A consumer means a patient who has improved and will tell his story to different groups of students. This helps the person who's listening to realize that persons who are mentally ill and get treated by a mental care team can recover and be productive. And last but not least, we should include psychiatry as a major component of final exams, and by doing so, it emphasizes the importance of it. Because as you know, there's no good health without mental health. Then in the media, what do we do in the media? Well, we have workshops in media houses, and that way we can help to understand, we understand how to interact with the media, and we also can encourage the media to do responsible media reporting and portrayal of mental health issues, and to ensure that persons realize that a balanced view as to mental illness, the mentally ill, and treatment they are receiving by the mental health worker. Also, as mental health workers, we should make ourselves available as experts in speaking on psychiatric issues in the media. Because if we don't, others will speak, and will speak out of ignorance and cause more stigma to be attached to us and to our patients. And we need to have a working relationship with media, providing information bulletin and press releases. And this can be championed by national associations like the Jamaica Psychiatric Association and Jamaica Psychological Association. But we as mental care workers, we also have a responsibility to ensure we portray a good image of what we are doing. So we need to make sure we develop a respectful relationship with our patients and their relatives. Because if we don't, then they're the same one who will say negative things about us and cause other persons in society to think that both our work and our worth is not worthy. We need to stay on the cutting edge of what it is to practice psychiatry to ensure our patients get the best treatment and the best outcome. So again, it'll give a good image. And we need to make sure we observe ethical principles, because in a caregiving profession like mental health, there are chances that person can be abused. And when abuse occurs, yes, it gives a negative image of our profession and put us in a bad light. We also need to collaborate more with our medical specialists and other health workers so that they can get involved in the care of people with mental disorders and become more comfortable and cast less stigma against us because of our profession. So in conclusion, stigma we face is due to negative attitude of others and the policies that they make, but also due to our own attitude towards ourselves. We may be internalized from what others have been saying and what we perceive the society members are saying, whether it's our family members, friends, or the general society. As you mentioned, stigma has various roots, and in reducing stigma, we have to approach it in several areas. The general public opinion is one area we need to address. We need to do the training of healthcare workers. So from early in their career choice as being the dentist or the general nurse or the physiotherapist, they'll have a good perception of psychiatry, the mental health workers, and the patients. We need to review the practice of medical care, or we deliver medical care, or we decrease the ostracizing of where the patients are treated in the primary and secondary care system. I mean, encourage responsible media portrayal of mental health issues. And we ourselves have to practice psychiatry at a level that it demands respect from others. So stigma reduction toolkit can be seen like this, where we start off with contact, which may be in-person interactions or doing training or vicarious interaction through print, audio, or audiovisual or now social media. And that is hope will cause an enlightened perspective of the mental health worker and their patients, will cause an enhanced knowledge, move from being ignorant to being knowledgeable, and cause them to question their stereotypes they have of persons who are mental health workers. And it should reduce the anxiety about interacting with persons who treat mental health persons or making referrals to persons or the mental health team. And then the outcome, there should be lower prejudice, less stigma and less discrimination. And this reduction of stigma will also provide greater access to care for everyone, everywhere. Thank you for your attention.
Thank you very much, Dr. Goulbourne, for that inspiring presentation. And I'm really very interested in the topic because you know that we operate this safe space for our youngsters after school. And one of the services that we offer is mental health. And just the very name is stigmatized by the young persons. And so I was so happy that you brought out this toolkit. We're training of our staff and also the young person to recognize that they should not stigmatize the name.
Yes.
So I thought that was really very insightful this afternoon. So we'll now open the floor for questions. Questions for Dr. Goulbourne? And what is interesting too, you mentioned early on in your presentation about how our peers see us in our work in mental health. And I thought that was really interesting.
Yes.
You want to expound on that because you did mention when one of your colleagues saw you at Cornwall Regional and he asked what field you're into now. And his expression, I thought that, wow.
And that's very significant.
No, I said that was a wow moment for me. Please go ahead.
Yes, and that's very significant because if our colleagues don't value our work and what we are doing, it means that they may see patients, and that have happened where they see patients who definitely have a psychiatric problem, not sleeping well, not eating well, signs of depression, for example, and with those give patients sleeping tablets over time and be either afraid or unwilling to refer patients to see us. And we got a patient who will be depressed for a longer time, and longer person is depressed, and when referred late, chance of recovery becomes so much less. And so it's important that healthcare workers who are not in the psychiatric field recognize our work and our worth. So when they have persons in their charge and they see signs and symptoms of depression, yes, they can initiate treatment and initiate accurate treatment or the proper treatment. But when the treatment is not working, then they ought to refer the person for further expertise intervention, or else the outcome is so much worse. And that's what we see happen when our colleagues who are not in the psychiatric field are stigmatizing our work and do late referral of persons who are in their charge who have mental health issues. So it's very important that our colleagues are on board in accepting that mental health is a real condition that needs treatment and treatment early, diagnosis early and treatment early is a key ingredient for good outcome. And that has been substantiated by what we look at a mental investment case, which was sponsored by PAHO, which showed if you have early diagnosis and treatment of mental illness, and look at anxiety, depression, and psychosis, then the person will return to reasonable function, become more productive, and the return on your investment is so much more. There's so much more savings to be garnered by that early intervention. Rather than when you wait late for intervention, then the person will be less productive and be more burdened in society and also a poor quality of life.
I see a comment here in the chat. Somebody is saying that some of the persons who stigmatize us are persons who we work with. So it really supports what you're actually saying.
Yes.
But there's also a question too. What policies are in place for healthcare workers who also suffer from a mental illness?
Okay, for healthcare workers who suffer from mental illness, we have in some regions, and we're trying to establish across all regions what we call employee assistance program. So if the person, whereas he or she is showing early signs of mental illness, so not sleeping well, not able to concentrate well, not having the motivation, drive to do the work, or having confused thoughts, they can actually seek assistance from the employee assistance program, in which case they can go on their own. At times, they may have to be referred by their employers if employers recognize that something is happening that suggests that they are not mentally well. So we do have this employee assistance program that can provide assistance for persons where it can have initial intervention, where it's going to be counseling, psychotherapy, and if necessary, they can be referred for medication treatment that is deemed necessary.
Thank you for that, Dr. Goulbourne. And there's another question as well. What can be done to help healthcare workers have a different approach towards the dealing with psychiatric patients and the psychiatric nursing aides in a hospital setting?
Well, it's a difficult case, especially when you're a person who will have formed his opinion over a long period of time. But what I found quite useful, especially when I was working in Stigma Hospital, when I had my mental officers, who are specially trained nurses, go on the ward, and they are part of managing the patients on the ward, then you find that the other healthcare workers become less afraid, become much more comfortable in dealing with these patients on the ward, and they have a better attitude towards the different workers, including psychiatric nursing aid. So what needs to happen is to have more contact with patients under supervision so they can develop that comfort level and understand how to deal with the patient. A lot of times, persons are afraid to do anything, are afraid to approach these patients because of misconception that all mental patients are violent and not knowing how to talk to them. So it does a matter of having a kind of ongoing interaction, and sometimes we have to actually do refresher course and train persons as to how to approach and how to deal with persons with mental ill according to different conditions they may have, because there are different approaches according to how the person presents. So a person who is very suspicious, for example, then you make sure when you interact with a person, you know, whisper going to a next person, but you'll make sure you speak to the person, be honest with the person, and try as much as possible not to be in any way behaving as if you are hiding some secret from them, because they become very suspicious, and become very suspicious, they become very aggressive sometimes, verbally and otherwise.
Yes, interesting. And you know, you mentioned earlier on about the role of the media, because this is where we have to do some more work. You know, how they package mental health and how it's projected to the public. Yes. Because that really is an area that we have to pay some keen attention to.
Yes, we hope to have some maybe interaction in the media houses where we can actually show them the do's and the don'ts of reporting issues related to mental ill persons, and how to ensure at the end of each reporting that they do give a positive message as to how persons could get help, where they could call, where they could actually visit to get help, and also make sure they don't put all the negative details within the employable reporting, and trying to see how we can have a system where we can congratulate those media houses that are abiding by the guidelines that we want set for them, and trying to help those who are not to step up to the plate where they can actually be responsible in their media reporting. Because a lot of times they may not realize it, but their media reporting shape people's minds about mentally ill and about the mental health profession in general.
Indeed. I have another question here for you. Can a person with mental illness become a mental health worker?
Very good question. Yes, because one has to realize that having a mental illness, you can actually get treated and be adequately treated that you don't show any signs or symptoms of mental illness. And also such persons who are well controlled and no signs of mental illness and able to function, you might find that that person sometimes become much more understanding when they approach persons who are mentally ill, because they have been there, they know what it is when you are mentally ill and person don't understand you and people shout at you and so on. So they may handle mental persons with much more sensitivity, much more understanding, and might find that even have a better approach than those of us who were not mentally ill. So yes, they can become providers of mental care once they have stabilized and they have improved.
Great. So it's about management and how well they manage
Yes.
their situation.
Well, because someone will say that, for example, a person who's diabetic, can diabetic work? Can a person hypertensive work? Yes. But if the diabetes is out of control and it's very high and it's very drowsy and so on, then clearly you cannot work in that state. But when diabetes is under control, or the hypertension under control, and the person is feeling okay, then he or she can work. So similarly, we want to remember that mental illness, once it's controlled, the person can function normally like anybody else. And many persons will be surprised to know how many persons in their communities, how many persons in their workplaces, at school, who may be mentally ill, but control medication, and they're working side by side with them and they don't realize it.
Great. Excellent.
I must mention too that we have had experiences where persons have become mentally ill to the point they're admitted to the hospital and have been discharged and returned back to work, haven't gotten a clean bill of health. Then you have the employer calling and asking, how is that this person is returned back to work? Wasn't he the one who might out the other day? He can't come back to work here. So we have really a lot of work to do in terms of workplace stigma in the home, in the community, because people don't realize that person with mental ill can be treated, can recover, can continue to study sometimes. Some have gone on to pursue a higher degree, some have got married and have families and live a productive life. But the key is for us to ensure that the stigma is less, so you can access care early, get effective care, so you can recover and continue to be productive in society.
Wonderful. Yeah, I see something else coming in the chat. How can we help mental health patients graduate back into society? And are there any programs in place?
A good question. And that's where investment comes in place also, where a lot of times persons who are mentally ill and they would have, depending on when it happened to them, whether they have completed their education or they may have completed education and have a skill that I think one part of them not recovering fully, become functional recovery because they can't attain employment. So persons can assist, and we have seen when it happened before where persons have become mentally stable and that so those psychosocial determinants of wellness are not in place, and that keeps them back. Whereas if they get training and they get job placement, you can see that person transform. I know of a particular case where a patient actually got better, but she was not functioning so well because she realized that even though she was better, she couldn't take care of her needs, not even her monthly needs. But once she got a job within the hospital system, she was transformed. She no longer depended on her boyfriend. She was now living independently, and you could say she was happy as a lark because she was able to move from being just clinically recovered, where she had no signs and symptoms of the illness, to functional recovery, where she was now able to become a productive member of society, no longer a burden to anybody, and improve her quality of life. So one way we can really help is to really give persons this opportunity to really move on in life, where they can get a skill. If they don't have a skill, they can get jobs if they don't have a job, and those opportunities help them to move on. Some need housing, for example. That also help them a lot. So we have found situations where if they can get a plot of land, put on a house, make from food for the poor, that make a great difference in their recovery process. And then of course, the way we speak to them, that's even an important part. Because sometimes the terms we use to refer to mental health patients are what keep patients from sometimes taking medication, call them mad pills, or we call them mad head, and different terminologies would make them feel less than a human being. And now we tend not to call them persons suffering from mental illness. We want to refer them as persons living with mental illness. In other words, they are not the person, their mental illness is not them. They're living with mental illness, and they can live productive lives with mental illness. So the way we speak to them, the way we approach them is a very important part as a community to a person to really get better. So yes, you knew how he was when he became ill, or he maybe took off his clothes, he was very, very aggressive, said some unkind things, and so on. But when the person become better, then it's not possible to remind them of where they're coming from, but to assist them to get where they need to go, where they become very productive and become back into mainstream of society.
So I have one final question from the chat for you, because I know the magic hour is coming up for you now to leave. Okay, any instructions on home care after hospital release?
Yes, home care is very important because whereas we as mental health care professionals have a lot to do in providing when you visit the clinics and the hospital and so on, but the basic fundamental care at home is very important. So it's important then to ensure that the person take the medication regularly, that the person get enough sleep, person eat adequately, and also person exercise. And exercise is very important, eating properly is very important. A lot of patients will take the medication, we just stay before the TV, not doing much at home and so, because person say they are mentally ill and their nerves weak and they can't do much. And as a result of that, person may sometimes become obese and then have diabetes, hypertension, which is additional problem to the mental illness. So it's important then to provide that necessary support for them at home, necessary encouragement to comply with taking the medication, keep up clinic visits, and to as much as possible to resume normal living, to have activity at home, participating in doing chores, as I said before, eating adequately, sleeping adequately, and interacting with them is very important. So having conversation with them and making sure they feel part of the family. So that home care is a fundamental part. And when we are discharging patients, we always try to look at what is the social support system at home. Because we can do our utmost best in a hospital and get the best treatment and so on, but that home care is not there, you can bet your bottom dollar in a short order, they're going to relapse and come back into hospital. So we tend to look at that, and where it's not there, we tend to try to see how we can improve it by getting help from family members, friends, even church members, to ensure this person has the necessary support at home to ensure he or she is fully recovered.
I know I said that was the final question, but this is absolutely the final one because I know you have to leave soon. What promotion, this just came up in the chat, what promotions, example, radio, television programs, advertisement, are present that are geared towards reducing the stigma of mental illness?
Okay, so there are several of them. There's some that related to COVID. You may have heard even the Minister of Health, the Honorable Dr. Christopher Tufton, having several ads on TV about trying to remember that COVID can affect anybody and to remove stigma from it. Also, we have what we call a mass media campaign called Speak Up, Speak Now. And what that is trying to do is to help us to be aware, not to suffer in silence, but to realize that if you have a mental issue, it's good to tell someone about it, someone we can trust. And by speaking up, the person become aware of what you're having, and we also want person to listen up and listen now. So provide that listening ear, that supportive ear, so person will not only come out of the closet and be able to tell person about their condition, but also person be willing to listen and to provide that support that they need in order to get help and to decrease the stigma by helping person realize that mental illness is not a respect of person in terms of age, race, and color, and that's actually one of the advertisements we have on TV that speaks to the fact that it can affect anyone, but the good thing about that, it can be treated and can be treated adequately. So we do have media promotion, which will be step on phase 2 now in terms of trying to see if we can get more messages out there that is geared towards increasing person awareness of mental health issues, awareness of the help that's available, and to decrease the stigma related to mental illness.
Great. So I know you're going to be the host tomorrow, I believe, to moderate, because somebody is asking how can persons get their questions or to you and a contact and a department with the remainder of questions. So I suppose that could follow on tomorrow.
Yes, and I can also, there's also a contact that we have for Ministry of Health, where I put it in the chat from now, where persons can actually contact the Ministry of Health for further information. And also, if you go to the Ministry of Health website, there's also a section there which speaks about telling your story, which gives the person opportunity to actually tell their stories. But I'll put in the chat the website that they can contact us if they have further questions, further concerns, and they need further information.
Thank you so very much, Dr. Goulbourne. Informative, insightful, and well done. Thank you so much.
Thank you.
Okay, so that was Dr. Kevin Goulbourne, Director of Mental Health and Substance Abuse in the Ministry of Health and Wellness. Thanks again, Dr. Goulbourne. Our next presenter is the exciting Dr. Peter Gay Reynolds. Dr. Reynolds, she's going to be looking at strategies for addressing challenges of managing patients on an open medical ward. Wow, that's a biggie. Well, let's find out something about Dr. Reynolds. So, she's a consultant psychiatrist at Anote Bay Hospital. She's also a sessional psychiatrist in the Department of Corrections and a consulting psychiatrist with ITEC. And ITEC is an international training and educational center for health. Dr. Reynolds completed a Bachelor of Science in Chemistry and Biochemistry with first-class honors at UWI Mona before entering medicine, where she completed both the MBBS and DM in psychiatry at UWI. She enjoys reading, watching Netflix, landscape photography, painting, and liming with friends, even though today this can be done through WhatsApp, video, and Zoom, and Google Meets, of course. She is passionate about psychoeducation and having patients and their families actively participate in their collective mental wellness. Ladies and gentlemen, let us welcome Dr. Peter Gay Reynolds.
Thank you so much for that welcome.
Ms. Chambers, thank you so much for that. I'm hoping that everybody can hear me very clearly. I'm about to share my screen with you so that we can start today's conversation, right? So hold on, let me just get this into full screen for you. Everybody's hearing okay, no concerns? As you can see there, the topic for today is strategies in addressing the challenges in managing patients on an open medical ward. And when I got this topic, I thought to myself, boy, Dr. Crossman really trying to set me up. But I think, it's really important that we have this discussion because mental health and how we do mental health care in Jamaica is slightly different from a lot of the places across the world. So it's important that we have this conversation. So let's go back a little bit first, and Dr. Goulbourne alluded to some of this, that initially, in terms of how we gave mental health care, there was a building that was adjoining the Kingston Public Hospital. And at times it was considered to be very barbaric, that they were poorly treated, persons were not being fed properly, not being clothed, hygienic needs were not being met. And because of that, there was a big push for an institution to be developed for mental health care. And so in 1861, we had what we call the Jamaica Lunatic Asylum. Now you can already hear in the terms that are used, lunatic asylum, that there will be a stigma already associated just by the name of this institution. And this institution came into existence right there on Widward Road in Kingston. It was later, the name was changed to Jamaica Mental Hospital in 1938. And now we know it as Bellevue Hospital. In 1946, it got that name. So prior to 1974, there was only one treatment facility for the mentally ill, and that was Bellevue Hospital. So anybody who had any mental illness would have to be picked up by the police and driven all the way to Kingston to Bellevue Hospital. And in 1974, there was created a community mental health service. And that happened by taking mental health officers from Bellevue Hospital and deploying them into the community to provide mental health services in health centers as well as general hospitals. And that is what we come off of now. So today, this system continues with Bellevue Hospital remaining the only specialist hospital for mental health services. And now we have 2 specialist wards at Cornwall Regional Hospital as well as at University Hospital. However, we are now able to admit patients with mental illnesses to general hospitals island-wide. So in the general hospital, patients are being seen by trained medical and nursing practitioners who assist in the management and their treatment. And this is done side by side beside patients with hypertension, diabetes, heart disease, heart attack, cancer, and currently now in our COVID setting where the wards have been pushed together with surgical complaints as well. And this is now done under the supervision of the community psychiatrist, right? Now, the treatment that's provided is free of charge, and it includes a twofold system. You have your acute management and your maintenance management. So in terms of the acute management, that's the emergency assistance. Sometimes persons call for help in bringing persons into hospital. We have the emergency line, which is national, which is 888 New Life. We have emergency treatment being provided at all hospitals and admission to general open wards, the specialist wards, along with Bellevue Hospital. In terms of maintenance management, we have clinics island-wide providing mental health services. We have home visits for patients who might find it difficult to come into clinics and travel. Now, in the context of COVID-19, we've been able to provide telepsychiatry and telepsychology. We have increased community engagement and education. So we go out into the communities, meet with workplaces, the JCF, with the court system, and do education. We have grooming and cleaning activities coordinated with community members, and that's all part of the maintenance management for our patients. Now, I put up this picture, and as I saw it a while ago, it just evoked a response in me, and I just felt a little bit sad. But I don't feel like I can talk about management of patients in open wards without giving a little tribute to Professor Hickling.
In my time as a resident, Prof. Hicklin was the one that was fighting this fight. You know, he was the one that taught us about the fact that you can manage patients, even though we were being trained in a specialist ward, that patients could be managed on an open ward, that this could be done. And in fact, he did a research along with Miss McCallum, Miley McCallum, who I had the pleasure of meeting as well. And that was published in in Psychiatric Services, an international journal in 2000. And that looked at the treatment of acute schizophrenia in open general medical wards in Jamaica. And the majority of the persons looked at were still admitted at that time to mental hospital. However, what they found is that the three groups of patients, so those admitted to general hospital wards, psychiatric units, and the mental hospital, they didn't differ significantly in terms of their symptomatology or their severity of symptoms. However, what they found was persons who stayed in general hospital medical wards tend to stay shorter periods in hospital, and persons admitted to the mental hospital tend to spend longer in hospital. They also found that persons who were managed in a general ward tended to be more compliant with treatment and actually tended to rebound back into employment much faster than persons that were admitted to mental hospital. So that gives credence to what we're doing. So as I mentioned before, I work at Anota Bay Hospital, and thought I would show you a picture of Anota Bay Hospital there. In the picture below, that is actually our ward. So below to your right, you'll see downstairs is a surgical ward and upstairs is the medical ward. And when we're talking about challenges, we'll speak about those challenges in terms of the infrastructure. But generally speaking, in most general hospitals, you'll find that the surgical ward is on the same level as the operating theater. So at Anota Bay Hospital, the operating theater is downstairs. Therefore, the surgical wards are downstairs. However, if you were to go to Port Antonio Hospital, where I also work, the surgical area is upstairs because that is where the theater is. So the medical ward is actually downstairs there. And I just decided that right now at this moment, you know, for our own mental health, I would just show that lovely view that our patients have from Port Antonio Hospital while they're on the general medical ward. And so you can just take a look at that and understand why they might be getting better a little faster. So what are the challenges? So the challenges stem from different issues. There could be patient issues, staff issues, community factors, administrative issues, infrastructural problems, and issues in terms of providing therapeutic activities for patients while admitted to an open ward. So in terms of patient factors, I want you to remember that these patients are being admitted in their community. So that means that they might be on a bed beside their cousin, beside a family member, a community member. And because of that, sometimes when they initially come into hospital, the behavior might be disorganized. They might be shouting, they might be saying things that they normally would not say. And as such, there might be some embarrassment that comes from that. And so sometimes because of that, we have to quickly start working with the patient in terms of recognizing the symptoms, understanding symptoms, and sometimes work with the community and the family members as well, understanding that these are symptoms and this is not the actual person. So these thoughts that are coming out, the things that were said are not of that person. This is because of their illness, right? The use of restraint. So a lot of patients will have issues with being restrained physically. In that picture there, you see the Pinel restraint that we use quite commonly in hospital. And we want to make sure that for the patient's integrity, that this is only used when it's absolutely necessary, when they're considered risk to themselves and others, right? It's important that you recognize that both the medications as well as the illness can sometimes cause patients to have restlessness. And as such, they want to move around, right? Now, on an open ward, sometimes, especially because of the stigma and discomfort, persons might be uncomfortable with them walking up and down the aisles of the ward. And so as soon as they improve and they're not considered a flight risk, then we actually allow them to go on walks with the staff, with the psychiatric nursing aide, just to allow them to burn off some of that excess energy that might be, you know, just bottled up inside. Also on a ward, remember, mental health care is also supposed to be rehabilitative. So the aim is we don't want patients in bed the entire day, right? We do want them to have some activities because this is what would happen if they were actually home. So at Ward 21, where I was trained, you would have different activities throughout the day. And we try to do the same thing on the open ward. So we use board games, so dominoes, Ludo, cards. And what I find, and I think it's quite lovely and it helps to reduce the stigma, is that as our patients are getting better, you'll find that a patient who's recovering from pneumonia, a patient whose hypertension was previously uncontrolled, is now sitting out on the balcony and they're all playing dominoes. And, you know, the usual domino fight about who giving who six love, right? And I think that's just a fabulous way of showing you how this integration actually helps in terms of reducing the stigma. During sporting events, it's important that the TV is functional, that it is working, and that it's on. You know, you can't have Jamaica and World Cup going on, and there's no way for them to watch football. Some persons like to write, like to draw. We need to give them access to those kinds of things. Of course, in some cases, those have to be supervised. Puzzles, books. So we want to encourage activity. We don't want to encourage them to sleep through the entire day. We want to work on their insight into the need for hospitalization. So that's the most common reason why patients might be at flight risk or try to leave hospital, because they don't see the need. And so it's important that we try to highlight to them, you know, the family member that brought them in, what were their concerns? Do they think those concerns are valid? And how do they think that we can help to reduce those issues or those problems that they're having with family members, all right? Other patient discomfort. So we have the other patients on the ward. So when our patients first come on, we might have a patient who is on the ward suffering from migraines. And then we have a patient here for a mental illness who is loud and boisterous and not sleeping through the night. And it's important that we adjust medications very quickly, that we respond quickly so that we can make sure that everybody is well cared for on the ward. We want to be open to other patients and their relatives' complaints. So one of the things we all need to be, as medical practitioners, we need to listen. So if another patient is concerned about something, they feel uncomfortable about something, we need to stop, we need to listen, we need to hear their relatives out and find ways to minimize their concerns and also minimize the disruptive behavior of our patients. In so doing, we work with communities, we work with the schools to try and increase the awareness of mental illness so that people can recognize the symptoms and understand that persons who may have symptoms of a mental illness or had been admitted to hospital are not always having these symptoms, that when they are well and when they're taking their medication, when they're getting their follow-up, you should not be able to recognize those symptoms. That's our aim, right? We also, as somebody asked the question earlier, we work with employers also to understand, to recognize the signs, work with them in terms of making sure that they understand, you know, what to look for to reduce the risk that that person may become ill again in the community. And sometimes we have to have actual face-to-face sit-downs, of course, with the patient's consent to discuss, you know, the progress and the expectations and the prognosis. Now, staff factors. I think that picture actually comes from Western region. So staff factors, we want to look at the discomfort that a lot of staff members have with dealing with psychotic patients. And it doesn't make sense. It's a significant challenge, and it does not make sense that we pretend that it doesn't exist. So we have to allow staff members to vent. We have to allow for that open and frank discussion about their concerns. We need to help them in terms of dealing with the aggressive patient by ensuring that there's adequate staffing, by continuing to push for adequate staffing, by training staff on de-escalation techniques. So it doesn't require long years of mental health training for you to learn how to de-escalate a situation. And it's really important that people who are working on the wards and also just persons working in the community, working at, you know, at schools, etc., learn how to do de-escalation. We want to make sure that the staff is very clear on the chemical restraint options that are available and that they're comfortable discussing when they feel that a patient might be at risk or that there's something that's happening they're concerned about. We want to make sure in some cases that the patient can actually be managed on the open ward. So yes, we speak about managing patients on general open wards, but if we have a severely aggressive patient, one who is very difficult to sedate, and we're having significant challenges with that, then we have to consider the well-being of the entire patients, all of the patients on the ward. And as such, this is when referrals to separate institutions where there might be closed wards or to the Bellevue Hospital may need to happen. There also is the issue for staff sometimes, and a lot of my staff members have come to me about this, where we admit patients who have a significant traumatic history. And as the staff get close to them, they start to divulge some of this information. And for the staff, it can be really challenging to hear some of these stories. And I'm telling you, it's really sad and disheartening when you hear some of the stories out there. And so we need to be available. And Dr. Goulbourne mentioned the Employee Assistance Program, EAP. So we also have that in NERHA, where myself, as well as the psychologists and the social workers, work together with staff who feel like they are being challenged or they're overly stressed, or if they themselves are having any mental wellness problems. The other issue for staff is that sometimes your psychiatric patient can take additional time to manage. And that can be very difficult, especially right now, where the work demands are so high, where people, because we have staff on quarantine and things like that, we are working extra sessions and so on, just to be able to ensure that adequate coverage is occurring in the health sector. Now, I'll give you a simple example. Just this week, I had a patient who refused to eat or drink for a day. And when I went to them, I asked them, what happened when you tried to give her the food? You could tell that the staff was a little frustrated, that they had been offering her the food, she hadn't tried, and you could just see the frustration in them. So I said, no problem, let's get the breakfast, let's go down to the bedside. And when I went to the bedside, what I noticed is that the patient kept, taking up the drink and putting it to her mouth and then pausing and then putting it back. And she would do that repeatedly, but not actually take a sip. She would take up the fork, but then she wouldn't put any in her mouth. So no food would go into the mouth. And she was just there. And so I said to her, are you worried about the food? She didn't respond. So then I said to her, knowing that this was a very religious patient, so we have to be aware of the kind of patient we're dealing with. And I said, okay, why don't you pray? Why don't you pray over it so that you're certain that it is safe and that it is protected? And she did so. Granted, this prayer took about 5 to 10 minutes of us standing there with her in prayer. And when she completed that, she finished the meal. And so it's a clear indication that sometimes just to get our patients to do what is necessary for their own well-being, it takes a lot of time and it takes a lot of patience, right? As I said before, staffing. And it's important that we work together as a whole team. So it's important that no one person feels that they're responsible for the psychiatric patients. It's not just the responsibility of the psychiatric nursing aide, that we work together. And one of the ways to do that, I think, is by leading by example. So as senior persons on the ward, if a patient requests something to drink, we help them. We get something for them to drink if we're available. And I think that's important because it just shows everybody that we can all participate collectively in patient care. And so it's not specific. So I don't just help patients who happen to have mental illness. We help every single individual. The other thing is that patients may require constant monitoring. So some patients may be on suicide watch, so they need to be one-to-one and be seen at all times. There needs to be frequent searches, and this has to be done in a routine. So for example, for us at Anota Bay, the searches need to occur every time shift changes, every time people visit, because that's when strange things come onto the ward, and you'll be surprised the things that we have found in doing so. So I've already mentioned the support staff, adequate support for staff, and the appropriate and timely use of chemical and physical restraints. So if you have a very psychotic patient, it's important that we use the chemical and physical restraints if we feel that that person's at risk of hurting themselves or another patient. I mentioned already the open discussion with staff about the patient's management and their diagnosis, allowing them to express their concerns. And also we need to recognize, especially as physicians, that we are not on the ward all the time. So a lot of the symptomatology is going to be seen by the nurses, by the orderlies. And so we need to be open to their input as well. We need to liaise with the nursing departments to ensure continued training sessions. And as I said, mentioned earlier, the de-escalation techniques, make sure that staff is trained and debriefing them, listening to their concerns. Now, community issues. Now, because of the stigma associated, there's this thing sometimes that people feel like all psychotic patients should be managed at Bellevue. They shouldn't be next to my relative in the hospital. And education, education, education. So it's important for people to recognize that persons with mental illness are no different from us, that any one of us, given the appropriate stressor and the previous genetic factors, could also develop a mental illness at any point. And so there's no point in us separating these people or considering that they are different from us or separate from us, but instead recognizing that we are all one, right? The other thing we find is that there's this concept that if a patient is admitted to a general hospital, they're not so bad, versus if they're admitted to Bellevue or Ward 21. And that's another concept that needs to be changed, because care is care, right? And we need to recognize that care is provided everywhere, and good care is being provided. Also, the community factor for healthcare workers. Somebody asked Dr. Goulbourne that question: what's in place for persons who are healthcare workers who also have mental illness? If they need to be admitted to a hospital, we do try as much as possible not to admit them to the hospital at which they work. And the reason for that is that it's very difficult to command respect after you've been admitted to a particular facility and work at that same facility. And so we try as much as possible to allow for that. However, there are some healthcare workers who have pointedly told me that no, they want to stay at their hospital because they know the staff and they know that they will take care of them. And so, of course, we need to take into consideration the patient's request as well when it comes to that. The community, sometimes the patient in the bed beside us feels like the treatment or the management is unjust. So, for example, a bipolar patient who's talking a lot, might be a little bit irritable at the time, and they're getting better, and they are not necessarily very aggressive at that point, might be beside a patient who has had a heart attack. And as far as that patient is concerned, they don't really see nothing wrong with them. So they feel like it's unfair for us to keep them in hospital and refuse to allow them home. And so again, it's only education of the population that's going to allow them to understand why at that point it's felt that the person is not quite ready yet for home. So I alluded to this one before, which is the infrastructural issues. So as I told you before, our ward, the medical ward, is upstairs there. And normally the surgical ward is downstairs. Now, I'm not sure if you can see it, but there's a man right there out on the balcony leaning over, right? And there are usually two doors, one in the middle of the ward, one to the side of the ward, and they're on both sides of the ward. One actually goes straight down to ground level with a staircase. And so it's very important that we monitor those access points and egress points. There are areas, the ward was not constructed specifically for managing psychiatric patients. And as such, there are areas that are low visibility. The areas, sometimes the sluice room is beside the bathroom. And so we need to make sure that all chemicals, all things that are being stored there are appropriately stored, that they are locked away. Sometimes we have to work with there's maintenance that's going on the ward. And a lot of times the maintenance people don't understand the importance of making sure that they always have eyes on the equipment, that they're right beside them, and that they make sure that when they leave, that everything leaves with them. And so these kind of things we have to be constantly alert about. It's something that I constantly work with the nursing supervisors so that we can ensure that these little issues don't come up. The movable oxygen. So our wards don't have oxygen flowing from out of the walls. So instead we have a huge oxygen tank that has to be moved back and forth, right? And of course you can imagine this is, if somebody was significantly aggressive, this could be an issue. And so we have to be thoughtful about that, about where we place them, about the access to them, about where we are in terms of how close we are to our patient versus where the oxygen is. And so all of these things we have to take into consideration and can be challenging. In terms of our therapeutic activities, as I mentioned before, we play a lot of dominoes at Petagaye and at Port Antonio. A lot of dominoes and a lot of Ludo. So much so that we have to have Ludo boards like at least two or three times a year. We need a new one because it's completely deteriorated. The issue is sometimes limited space, but luckily we have verandas. So those verandas look out to the sea at Petagaye and also look out to the sea or the mountains. Well, mountains and sea for Port Antonio as well. And so it's a really nice place to play some domino or play some cards. Sometimes, however, we don't have the staff may not have time to participate in these activities. And so a lot of times we have to look at the allocation to make sure that we have enough staff so that we can ensure that activities like this continue to go on. I want to also mention that some of our staff members, you know, some people play dominoes, some people comb hair. And so sometimes I'll see a patient who is really good at combing hair or who is a hairdresser normally. One of their activities, they might decide that they want to help to comb another patient's hair. And these are things we should encourage because we're trying to encourage people to get back into their normal routines. Safety. So as medical practitioners, sometimes we have a bad habit of leaving a scalpel, leaving a needle, leaving syringes about the place. This is something ongoing with medical staff that we have to keep on reminding that, look, we can't do these kind of things. It should not be happening any at all, whether or not we had psychiatric patients. These things need to be disposed of appropriately. And that's just something that we have to work on continuously. And I think that would be the case regardless of whether psychiatric patients were admitted to the ward. Administration. So in terms of administrative challenges, it's really important that they understand the need for staffing. And, you know, Dr. Goulbourne alluded to this importance of making sure that administration understands how the worth of mental health. So sometimes our colleagues, the people we're working with, see it as Baksha breed of medicine, right? And so it's important that we get them to understand that as psychiatrists, the work that we do, we are required to be able to rule out all medical causes before coming to a psychiatric diagnosis. That means that our medicine have to be top of tops, right? And so when thinking about it in that way, it's important that we let them know what kind of staff we need to ensure that there is good care provided to the patients. Sometimes there's need for infrastructural changes. So like at Port Antonio, there were issues with the bathrooms in terms of the bathroom windows were so large that people could climb out of them. And so these things had to be adjusted and dealt with. The need for continued on-the-job training. And I've been very blessed to work with, you know, matrons and nursing supervisors who see this as very, very important and will continually call on me to make sure that on-the-job training continues to occur. So I've spoken about education, and I just want to highlight, so those 3 pictures there were actually from last year's World Mental Health Week. And this is actually in Gale St. Mary. And so this is the team along with some children and community members. We're just going out there, exposing ourselves to them, trying to reduce that stigma, let them see that the mental health care workers are not strange or mad people. Or sickheads, and just allow for that kind of integration with the community. And the whole aim of that is increasing knowledge of mental illness and reducing the stigma. And I think it's important that we work especially with younger children because they're the ones coming up, they're the future. And so if we work with them, they carry that message back to their parents, they carry that message to their church, they carry that message everywhere. So working with children is very effective in that way. So what I'm saying to you, and the one take-home thing that I want you to understand is that the main strategy for managing patients on an open ward is actually open communication and education. Those are the major strategies that we employ on a regular basis to ensure adequate care to our patients. So in conclusion, there are many challenges in managing patients admitted for mental health issues. However, the benefits outweigh the challenges. Patients can be now managed closer to their homes. That allows for their family to participate in their recovery. It allows for us to have family meetings where we can discuss with the family members the prognosis, what to expect, what to look for, the importance of medication, the importance of follow-up. And it also allows us access to that same community. So if we're finding that we're having a patient who's having a challenge, and sometimes the patients will say to us that when I walk in on the road, I don't like how people call to me or what they say about me. And so we can address that. We can go to that church. We can go into that community center and do talks on mental illness, focused on making sure that persons understand and, destigmatize the concept of having an illness. It also allows for increased access to care throughout the island. So remember, I told you before, they used to have to pick up somebody from Montego Bay and drive them all the way down to Bellevue Hospital. No, you have somewhere in Montego Bay that they can be, you have somewhere in Falmouth they can be, you have somewhere in St. Anne that they can be, and treated adequately. It also allows for an early integration between the acute management team and the maintenance management team in the community. So we are blessed in NERHA of having the acute team blending with the maintenance management team. So when the persons come on the hospital, they meet us, that we start to work with them. We do the psychoeducation with them. We work with them in terms of their medication and their concerns moving forward and their future plans. And then we can translate that when we refer over to the maintenance team. They come back and they see us in the room. They see us there as well. And so there's a integration between the care. As I said before, we find that this hospital stays tend to be shorter in the general hospital. It also allows for ease of access to treatment regimes. So if a patient is in their community and being treated, so they're treated, say, at Anoto Bay Hospital and they live in Enfield, St. Mary, or right there in the town of Anoto Bay, we can ensure that the medication regime that we start on this client is available in that particular area that they're staying, so that they don't have to try hard to find the medication. They don't have to struggle. They don't have to find additional bus fare to go and pick up medications. It also helps to reduce the stigma against mental health issues. So this exposure, persons are exposed more. So this means the interns, the residents, other doctors, the specialists, the nurses, the orderlies, the nursing aides, the cleaning persons, everybody has been exposed now to persons with mental illness. And that exposure helps to reduce the stigma. When they sit down and they play dominoes with them and find that our patients quite often do way better than them. When they sit down and have long conversations and realize that they're able to learn things from our patients, then that just changes the whole perspective, this whole concept that people have that mental illness means that you're fool or you're an idiot. That's not true. There's a lot to be gained from sitting down and listening to somebody who has mental health issues as well. It reduces costs. So it's cheaper to manage patients on an open medical ward versus in a specialist hospital. There's a quicker return to employment in many cases, and it allows for us, where the patient desires it, to interact with their employer much more easily. And in big summary, all of this, treating patients on open wards in their communities, assists in reducing the stigma against mental illness. And I thank you all for paying attention and listening to me. I appreciate it.
Thank you, Dr. Reynolds. That was really, really informative and exciting too. I hear some words coming out: integration, ongoing training, listening to your patients, and education. And I think that this would be useful for us to, heed these words, because it's important that we listen. That's how we're going to be able to make some decisions. And also for persons who are educated in terms of how we deal with persons with mental illness, it makes a difference because the stigma will be reduced and there'll be more acceptance. And also when you integrate the different teams, that also helps. So I thought that was really instructive. There's some questions here from the chat. So we'll go straight to that now. Are measures being put in place to correct or adjust the points of concern that have been expressed?
So absolutely. So it's an ongoing situation and ongoing work that's being done. So we work continuously in terms of addressing issues in terms of staffing, working individually with patients and the community. Our child guidance team continuously throughout the year, even during the COVID pandemic, has been having sessions with teachers, sessions with counselors, sessions with children, sessions with children's homes, just trying to ensure that we reduce these stigmas. So this is an ongoing thing, working with administration, working with staff, working with patients to ensure the best possible care.
Great. Another question is, can all patients be managed on an open general medical ward? Is there still a need for psychiatric units and hospitals?
Well, I alluded to that before. So I am of the belief that there is still a need for specialist wards, that there is still a need for a specialist hospital. And yes, I agree that I do not believe that every single patient is an appropriate candidate for management on the open ward. However, the majority of our patients can be managed on an open ward, and we need to facilitate that as much as possible. So as much as possible, we need to keep patients close to home.
Okay. Another question is, are there more or less COVID cases among the mentally ill?
All right, so I would have to give that one more anecdotally. So anecdotally, in my experience, I've not had as much cases of persons with mental illness admitted to wards. As to the ones that are being managed at home, who might be in home quarantine or home isolation, yes, we have quite a few patients that are being managed in home isolation. But I don't find that the figures are any different, or the statistics are significantly different for persons with mental illness versus persons without. What I do find, however, is that there are a lot of persons having challenges in COVID-19 who have been placed under isolation. So I've been called to isolation wards quite often because of people having difficulty dealing with being separate. Human beings were not created to be isolated. Right? There's a reason why God created both Adam and Eve. Somebody needed company, right? And so these things create a lot of stress a lot of times. And initially in the early phases of COVID, when we were admitted persons to ward, there was no internet access. The persons couldn't talk to their relatives. They didn't have credit. Over time, we've dealt with these issues. So we've ensured that our facilities now have access to the internet. And if not, we ensure that we try to make sure that they have credit so that they can talk to their family members, that they can vent and so on. So overall, I would say you have not noticed increased numbers amongst persons with mental illness. However, yes, we do have persons suffering from both issues that we are managing.
And yet another question, can there be a synchronized care plan for all hospitals within NERHA and other regions in how psychiatric patients are cared for?
So the answer to that is yes, there can be. The main issue, as I said, will be staffing allocations to ensure that that is actually equivalent, what is available is equivalent, and also having somebody to completely coordinate those events. So that's something that, the region and the regional technical director, we need to work with them on trying to create and ensure that across every single hospital, people are confident and comfortable that the care is exactly the same.
Okay, and yet another question. As a medical officer at type B or C hospitals working in internal medicine, what are key steps in the management of patients with psychiatric presentations, and how often should they be reviewed?
Okay, every single patient should be reviewed daily once they're in a hospital setting, right? So I want us to remember that even though a patient is admitted for example, schizophrenia or for bipolar disorder, that does not mean that they don't have other organ systems, that this person is not also 50 years old and at risk of developing hypertension, that this person, due to the injection sites where they got medications, that there cannot be infection. So it's important that we're monitoring all of our patients. We're looking at their vital charts, we're looking at their treatment charts, and we're treating them just like everybody else. There should be no difference in the treatment that is offered. In terms of what a medical officer should do, that's exactly what I want you to do. I want you to think about the patient as a whole and not just see them as a mental illness. I want you to see them as a whole person that has many organ systems, all of which could be fine and all of which could be deteriorating at this time, and just paying attention to those things. So we want to, be conversant with patients. As a medical officer, later on, you intend to go and work privately. Working privately, there are going to be a lot of persons that come to you with depression, with anxiety. And so you need to be comfortable with this kind of content. So, educate yourself, find ways. There's an MHGAP program, and MHGAP is also available as an app where you can put it on your phone so that if you're not confident in recognizing psychiatric illnesses, you can look on it as a master sheet with symptoms and you can go through that. So I encourage any medical officer to educate yourself, to keep your information at the top of your head. We don't want to forget things. When we were in medical school, we were trained to manage psychiatric patients. We saw psychiatric patients. We had a psychiatry rotation. And so you need to continue to educate yourself, and don't hide away from persons because it's a little bit more challenging or difficult, because there's still so much to learn and there's so much to gain.
I can hear the passion in your voice and see that you love what you do. And I'm sure your patients will be blessed just by having you there in their lives. So continuing with the questions. Okay, there's not another question. There's just some comments there, but not questions. Okay, any other questions for Dr. Reynolds? There's quite a lot to digest. And somebody says, I'm in support of the approach to the open ward practice. But what empirical data is there to support this practice?
Well, as I mentioned before, we have that research that was done by Professor Hicklin and Miley McCallum, which I alluded to in the psychiatric services. There's actually quite a few publications done by Professor Hicklin focusing on open ward management, deinstitutionalization. And what we've also found is that, currently now when it comes to mental health services, even PAHO, WHO has been pushing towards general doctors being able to manage psychiatric conditions. So the push generally is for us to not see this as separate and to separate mental illness from other illnesses, but encourage that treatment can be had everywhere for these kind of illnesses. So the push worldwide is towards integrating mental health care into healthcare.
Indeed. Wow. Well, Dr. Reynolds, that was awesome. Awesome presentation. And because the chat has been very busy. So if there are no other questions, I just want to use this opportunity to thank both presenters, Dr. Goulbourne, who had to go off to another meeting, and also Dr. Reynolds, who is still with us. So thanks again, presenters, and I'm sure that your audience have been well informed. Also, it is my pleasure to thank PAHO, the UWI Western Campus, the health team from Western Region, and of course, NERHA, because you represented well, Dr. Reynolds from NERHA. And the MOHW. Thank you all for this afternoon session 3, which I think is the best. However, I'm sure my colleagues will tell me yesterday was better or tomorrow would even be better. But I thought today was exciting, informative, and a very good afternoon. So thank you all for joining in, and see you tomorrow.
Thank you, everybody.